I was so pleased when I received a call to be a part of this presentation. It occurred at a time when our treatment team had just completed work with a very challenging patient and her mother. And the wounds from this experience were still very fresh. So this was such an appropriate topic. It actually also was a wonderful opportunity for me to review what had happened with this patient and her mother, and to really look at what we had done, what some of the obstacles were, and to very importantly ask what we could have done differently. And I came up with a lot of things we could have done differently. My objectives this morning are, first of all, to talk a little bit about how our current hospital protocols and environment may actually contribute in some ways to caregiver interference or obstruction in the delivery of care, how our present system can actually contribute to caregiver burnout. I'm going to share with you 2 case examples, and then hopefully at the end talk a little bit about what can be helpful interventions. We really all know of, through research done for many years, of the benefits of a helpful, positive support system when individuals are ill. From the moment we meet a patient with our, I guess I want to take a moment and explain. So I work with adult heart transplant patients. I've been a part of that team for 23, almost 24 years. But another important segment, and actually the 2 examples I'm going to give, are patients who have mechanical circulatory support devices placed. LVADs, the Dick Cheney device that he had in place. And more these are being used not only as bridges to transplant, but as what we refer to as destination therapy. So those are examples, and what I'm talking about in the work that I did since I came to the clinic. Prior to that, I had about 15 years of experience in outpatient mental health. So from the day those patients and family members walk through our door, the patient is our primary caretaker, our primary client, but we are certainly keenly aware of their family system, and our efforts are really made to work with both the patient and the family. I think it's for this discussion also important to keep in mind that most of the time our efforts, even when there are problems, go very well. We are able to resolve difficulties. So what we're talking about today, I think fortunately, is a rare occurrence, when really there are times when our efforts to remediate a situation just do not work. And that's what we're going to be discussing today. So I want to begin talking about does our present healthcare system and our environment, protocols we have, actually contribute to caregiver burnout? A burnt-out support system can certainly contribute to interference with patient care and obstruction with delivery of care. When I think of how protocols were in place when I began at the clinic 23 years ago, and I'll use the example of visiting hours. They were probably at that time on this end of the continuum quite restrictive, not very geared to what would be helpful to a patient. Well, how could their support system help them and work with them? I think through time, and right now we're maybe on this other end of the continuum, where we're very hesitant with our patient-first philosophy that has created some excellent things with patient care and being more tuned into patient needs. But I think it has also caused us to hesitate and to be almost a little afraid of setting guidelines and protocols, boundaries, frameworks that can actually help patients and families as they navigate this very complex system. So I ask myself frequently, has our pendulum swung too far? We're better than we were, but do we now need to try to find a middle of the road, a more middle ground with guidelines and boundaries that we set up? So what is the impact of ineffective coping of a support system? Well, they certainly can impact the patient's recovery. The second patient example I'm going to give, I think just really so displays how that ineffective coping of the patient's mother impacted the delivery of care. The support person may make decisions detrimental in the end to the well-being of a patient. They may have unrealistic expectations of the patient or the hospital care providers, and their display of negative emotions, negativity about the delivery of care, team members, are not helpful in the patient's recovery. When we think about guidelines and boundaries and framework, well, if you were sleeping, that woke you up quickly. Some families just so beautifully know how to set their own guidelines, their own boundaries, their own framework. We have a man whose wife was actually just discharged last week. She was in the hospital almost 4 months, and 6 months of that were spent in a cardiothoracic surgical intensive care unit. If you've ever been in a unit like that, they are wonderful places of delivery of care, but environmentally they are hellish with sounds and noises and no difference between night and day. And from the beginning, I was so impressed that he knew he needed to not be in that ICU all the time, that he knew he needed to take breaks and walk outside. He needed to make sure he ate. He needed to leave every night, drive an hour away, and stay with a family member. So he knew how to set those guidelines and framework and establish a protocol that worked for him. He was able to realize that if he took care of himself, he was going to do a better job of taking care of her. He also, importantly, knew how to use the support that those of us on our team were offering. And that is a tremendous skill and strength, I think, for an individual. So for many people that are able to do this, there are many, many people at this extreme time of crisis. The population I work with often come in an acute, enormous medical crisis, and family members become exhausted, depleted. This is a strange environment. For many of them, the number of people that work at the hospital is 3 times as large as the community they live in. It's a scary, frightening environment at a time when life is very uncertain. So I really question if we are doing those individuals a favor, are we really helping them by not setting guidelines? I think, again, as I mentioned in the last slide, one of the great examples is what's happened with setting boundaries with visiting hours. Again, many years ago they may have been too restrictive, but now there are absolutely no visiting hour regulations in hospital rooms and also in intensive care units. There may be some gentle guidelines given, but it pretty much is what that patient family wants. I want to share with you, and I think this will be helpful as we continue our discussions this morning, to share with you 2 patient examples. The first one I'm actually going to kind of whip through pretty quickly. Both of these examples are of individuals who ended up having left ventricular assist devices placed. But the evaluation process, the team members involved, it's our heart failure team that follows both transplant and these assist device patients. And I work with both of these groups, so they're very interrelated. So I want to share with you a little about this first young woman. She was a 27-year-old Caucasian married female. She'd known her husband for 10 years. They'd married 3 years. They had a little 2.5-year-old and a 3-month-old baby. She grew up, interestingly, on a farm. Her parents were both living. She was the youngest of 4, and she had 3 older brothers. She was a speech pathologist. She had a master's degree, and her husband was a teacher. Since her little baby was born, she had not felt well, and she just felt more fatigued, and she thought it was trying to take care of 2 children. She had already gone back to work. And then she developed some GI symptoms. Things didn't get better. She had gone to a doctor, and then finally one weekend her mother just insisted she go to the emergency department. She was admitted to a local hospital about 3 hours from Cleveland, and that was the first inkling she heard that these were likely not GI problems. There probably was a cardiac component to her illness. Within a day, she was transferred to our facility, and that's when she learned the true extent of her cardiac problems. She was diagnosed with a postpartum cardiomyopathy, and probably it was within another 24 hours, she was hearing about that she would likely need a heart transplant, and we had to look at how to keep her stable until she could have a transplant. And so the idea of a left ventricular assist device was presented to her quite quickly. So really in less than a week from the time she went to that emergency department, she learned she had a cardiac problem, and she learned she was going to need really the most aggressive of treatment options. A couple of things about how this family coped. Her husband was present most of the time with her. He would take breaks, so he also knew he needed to get away a little bit. Family members were there, but from the beginning, I noticed so many positive strengths with this group. They were very mindful of how many people would visit her in the intensive care unit, so she didn't become exhausted and overwhelmed. Her mother, I remembered, was always so attuned to making sure that the patient and her husband as a couple during this crisis had time that they were just by themselves. The family would frequently ask, and a lot of it was directed towards me, but other team members also, did we want time alone to talk to her? They were concerned she may not be asking all the questions and sharing some of her comments because she was worried about upsetting or frightening them. So that made it so much easier to be able to have some time to talk with her alone. The other thing, as I mentioned in another example, they really knew how to use support that was provided by myself and our team, both to the patient, her husband. I met many times with her mother by herself. When the mother was in the room with the patient, she was directing her support and energy to the patient. But when she could leave the room, she could really talk about how sad and grief-stricken she was that her daughter now had a chronic medical condition. And I will always remember the day she looked at me and said, you know, I know she won't live to be old. I know she won't live to see old age. So it was so helpful that she and that family could use the supportive interventions. The other thing that I will probably always remember about them was that they had a lot of plans and things they had to arrange. There were 2 little children, and they did all of this. It was like watching a synchronized dance. They would tell her what was going on, and they would keep her informed, but they did not trouble her with the details. And I think that was another strength of theirs. And I think that their behavior truly helped this young woman begin her ongoing process of adjusting to illness. I saw this patient last week. She's been discharged from the hospital. This all happened in April of this year. So she's been home from the hospital. She went home in July. She's doing quite well. She's back at work. She continues certainly to have some frustration. I don't know if any of you have ever seen pictures of left ventricular assist devices, but there's some tubes and wires and batteries. They are not problem-free devices, and she feels some frustration with that, and certainly feels hugely improved, but not as energetic as she did. Both the patient and family continue to use supports we provide very effectively. The second patient is one that the impact of this individual, in I think the 38 years that I've been a clinical social worker, I will say this was probably one of the top 2 challenging situations I've ever had to face. This is a young woman who came to us from another large university facility out of state, and I was at a meeting in September, and I happened to see the social worker who I had spoken with on the phone about this patient when she came to us, and I asked if she or the team that had originally cared for her talked about her or asked about her, and her response was so interesting. She said, no, they really hadn't, because it was so traumatic the time she was there that none of them could quite bring themselves to talk about the situation. So I thought that was so indicative of the magnitude of complications that were presented. So this was a 24-year-old single African-American female. She had, I think, graduated from college or was close to completing a 4-year degree. Her parents were divorced. She had 3 half-siblings. She had developed some flu-like symptoms in May of 2012. Things weren't getting better. She went to a local emergency department and lived maybe 30 minutes away from a large medical university setting. An interesting note just to make was that she also had an abortion performed that her mother did not know about and still does not know about 1 week before the onset of symptoms. She was diagnosed with a viral cardiomyopathy. She was evaluated for transplant at this other facility, and she was actually listed for transplant there. And in order to maintain her, stabilize her, one of these left ventricular assist devices was placed. She was transferred to our facility a month after the onset of symptoms. And this was really where we began to hear about this young woman about 2 weeks before she actually came to us. The mother was insistent on transfer here, and I think much of that we found out later was because the father lived in the community where the daughter was initially hospitalized, and the mother did not want him to have a role in this patient's care. The insurance could not justify transferring her here. There was absolutely nothing we were going to do that this very well-developed advanced treatment center where she was receiving care wasn't already doing. I had to speak to the representative from the insurance several weeks later and happened to talk to the person who worked with this mother, and I put in quotes. She said to me, I said, I just don't understand why the insurance agreed to pay for this transfer. And she said, the mom wore us down, and we eventually gave in. So she arrived at our facility in June. It was on a Friday of this year with her mother. I was informed of her admission, and I was also urged to please see her that same day because they didn't know how stable she was and wanted to proceed with evaluating and learning more about the situation. Typically, I always would meet with a young adult by themselves in order to just help with establishing a relationship with them, but also with hoping that they would be somewhat more forthcoming with information about lifestyle, how they cared for themselves. So that's a very standard practice for all of us that work with social workers that work with transplant patients. The mother immediately objected, questioned why I wanted to meet with her daughter alone. And no matter how I explained it, she continued to be questioning and concerned about that. She did leave the room. I began my meeting with completing a psychosocial evaluation, which was never completed. The patient was quite avoidant, kept her eyes shut much of the time, answered with brief responses. And then when I began to ask a little bit more about family history, she got angry and told me the interview was over and told me to leave the room. I did at that point, and that was actually when I made my first call to the social worker at the facility where she had come from. The mother sought me out about an hour or two later, told me I would not return again and meet with her daughter alone, and also told me what questions I could and could not ask her daughter, and that she was also going to find another social worker. That they didn't want to work with me. I was the first, I got to advance. I was the first of 12 of us, 12 different healthcare providers that were fired by this mother. Although I didn't allow myself to be fired, I was persistent and continued to return. So the psychosocial evaluation was never completed. I immediately called the cardiologist who was head of our program, who had accepted this transfer but was also on hospital service that week. And I advised him of the situation. I verbalized concerns about the mother's behavior, how out of the ordinary this was. And I, from the very beginning, verbalized concerns that this mother was going to split our team. I asked, as he rounded with this patient, that he please address this from day one. This was so important to do. And that guidelines and the protocol of our team and that we don't fire team members needed to be stated. This, unfortunately, was never done. The mother's behavior escalated. She was often angry, yelling. She would refuse to speak to residents or fellows who came in. She would only speak with staff. The patient limited excuse me, her interactions with team members and nursing staff. Interestingly, to the initial social worker and also to one of our team members, the patient did verbalize frustration with the amount of control that she was feeling from her mother, not only in this situation, but through her life. But she, again, never would speak of this. The patient would frequently refuse care. She'd refuse dressing changes, vitals, wouldn't wake up, wouldn't work with physical therapy. Psychiatry was consulted. She wouldn't talk with them. The mother would, interestingly, and this was certainly an ethical challenge for us, this was a 24-year-old, and the mother would not allow the daughter to make any decisions, basic ones, and the daughter went along with this. So all care plans had to be reviewed with the mother. The team surgeon attempted, along with one of our other cardiologists, to discuss the role of our team. I was present at that meeting, and later that day she fired the surgeon and that cardiologist. And I'd already been fired, but I guess maybe she fired me again. After I think 3 other cardiologists were fired, our team rotates hospital service weekly. The attending cardiologist who had been working with her when she first came in began to follow the patient. Discharge was probably delayed. Keep in mind, this young woman already had this mechanical assist device placed for a month. Their typical length of stay is 3 weeks or so after placement. Her discharge was delayed easily by another 3 weeks. And finally, the mother received a phone call from the insurance company saying that they would likely stop payment because all chart notes showed that the patient was ready for discharge. So the mother was determining by what her assessment was of the patient whether she was ready or not. There needed to be a defibrillator placed, and the daughter, people would come by to see her for this. She wouldn't talk to them because her mother wasn't present. The mother would be absent for 3 or 4 days, so everything was delayed. The patient's ability, the sad part also was so much had happened. A 24-year-old, she had an abortion, she learned she has a heart problem, she has an LVAD put in, she will likely, we hope not, but may need a heart transplant. And there were no interventions. There were no therapeutic interventions, like as was the case of in the first example I gave. None of that typical therapeutic interventions could happen. And I thought that was one of the most tragic parts of this. The patient clearly modeled her mother's very aggressive, demeaning, argumentative behavior. She has been discharged from the hospital, and that was in late July. She's still staying in a hotel on the campus. We really don't know where her mother lives. There continue to be all these enormous secrets. The patient is somewhat more engaged. We have a device clinic, and she comes to see us. She's actually coming this afternoon, but she continues very guarded, little exchange of information. Has certainly not formed a relationship with our treatment team. We have a protocol for our young adults that we always see them by themselves in this device clinic or transplant follow-up clinic, and then their family member joins them at the end. I often feel like when I see her, there are a herd of elephants in the room, many of these untouched subjects, and it's been really difficult for me clinically to know how to approach this. So one of the certainly ethical dilemmas we faced was a question asked frequently: did we have a right, did we have a responsibility to continue to provide care to this patient? Did we have a right to fire the patient, to inform them that they needed to seek care at another facility? We consulted our legal department and they provided some guidance. Bioethics was involved. We have a bioethicist that works with our team. We really made a point of having daily care discussions. I would every day see which nurse was taking care of this patient, and we would talk about what was happening and how to handle situations so we could attempt to be on the same page. What would have helped? I think the biggest, if we could relive these days, what would have been the most helpful would have been if there were rules stated to the family that first evening, or certainly the next morning, and that didn't happen. And I think that was our biggest error that we made. That was never defined clearly. This is how we work here. You can join and engage in our team, or we may not be able to continue working together. And that never happened. I don't think we were presented by leadership as a united team, and we really handed the power to this mother on a platter, and we allowed her to really split our team. And you know, the other part, I don't think we really followed all the recommendations that were given to us, especially by our ombudsman department. They had some really good suggestions, and I don't think, again, because of this lack of unity, that we followed through. So what can help? I think one of the important things with caregivers is that it's so important from day one, and something I certainly do in my interventions, to talk about caregiver stress and how they're taking care of themselves. Frequent monitoring: are they eating, are they sleeping? Daily collaboration with team members so we're all on the same page. As a mental health clinician, I think I often see things that are so important for us to work on, but when you don't have everyone buying into that plan, team-wise, but also nursing floor, others delivering care, it can be very problematic. We have a weekly multidisciplinary team rounds. Those are very beneficial. And I also think how I present my evaluation, or how I discuss how we deliver care, how we try to work and form a patient team partnership is important initially. Thank you.
My assignment was to focus primarily on the core ethical components of this issue, and I told my fellow panelists before we started, I think I have the easiest job of the three of us. Clinical ethics, I believe, actually has two aspects to it. One is to do the kind of careful analysis of the moral components, duties, responsibilities, things like that. But then I think perhaps an equally important piece is to help the treatment team actually do something with that analysis, to put it in place. But my focus today is just on the first half, so I'll leave the heavy lifting to Kay and Gerard. Let me start with just explaining what I want to do. I think when we think about family involvement, it's helpful to think of it as two components. One is in the decision making, the authority for decisions, and the other is in the actual involvement, much like Kay's second case. So I want to look at both of those a little separately, then talk a little bit about the moral basis for our responsibilities to allow families this engagement, look at the limits to those obligations, and then think just very briefly about the implications. So thinking about decision-making first, the reason, in a sense, the moral reasons why we authorize families to make decisions for patients rather than the patient himself are these assumptions I've laid out here. We assume that family members share the same cultural background, So they're likely to have the same values that will direct decisions. So we think we can use them literally as a proxy. They're likely to know about the patient preferences, even if they haven't had an explicit discussion of, the kind of what would you do if discussion. They at least are likely to be able to predict what a patient would say in a situation. And we generally assume that they're committed to the patient's best interest. Something we often don't think about quite as explicitly as we probably should is it's the family that will be with the patient after we shoot them out of our acute care system. So it's the family who will bear very practical burdens of caring for the patient and dealing with the outcomes. And then I put just in parentheses that with children, of course, we have the added consideration that they actually have legal authority, unlike adults, to make decisions for their children. So those are all assumptions that sort of sit out there in the context of what I think is a factual statement, that although we are equally committed to the patient's best interest, we rarely have the same cultural background. We rarely know much about their preferences. Healthcare today is pretty much strangers taking care of strangers. So given the choice, in a sense, of how well prepared are we to make decisions versus family members, it's pretty clear that the family is the default decision maker. So there's pretty sound moral basis for their role as decision makers. Now looking at the other component, in a sense, the actual involvement of care, there's lots of very good, I think, sound practical reasons why we like to have families involved. First of all, as Kay said, I think in today's world we recognize much more than we did back when I started practice, that patients don't exist in isolation. They're embedded within these family systems. So we may physically separate them sometimes from their family, but they are very much a part of the system. Family support is central. Most of us want to have people we care about who care about us around us, help us cope. As I mentioned before, families are affected by what happens to the patient, and patient decisions are often influenced by what they perceive as good for their family. And when you talk to patients at the end of life, in fact, concern about their family well-being is very high on their list of what matters to them. And again, there's some moral reasons. If our primary duty is to provide good care for the patient, that will entail attending to family needs. Okay? So ignoring that, it would be the same as ignoring their kidneys. We can't do good care without attending to the family. And then at perhaps the most general level, as healthcare providers, we have an inherent duty, this is the core of being a healthcare professional, to help others, to do good. And we consider that part of our general duties of beneficence. So just as we have duties, Good Samaritan duties to help a stranger on the street, we have duties to help a family who is in distress. So that's sort of all well and good as long as everything is going along fine, as in Kay's first case. But of course, things aren't always that simple. So thinking about that decision making, remember those assumptions that are the moral basis for letting one adult make a decision for another. The first one was that families usually share the same cultural background and thus the same religion, values, what have you. Well, that's not always the case, of course, and particularly in terms of spouses who are usually the next of kin. Sometimes they come from very different backgrounds, okay? Although they may be married and living together for a while, they may have some pretty deeply embedded values and beliefs that are quite different from each other. So that might be one, sort of red flag in a sense. Second one is that, we assume they can predict what the patient would want. That's their job, is to speak for the patient. But every clinician is familiar with the daughter from Texas, the son from California, who's actually been away from the patient for 20 years and possibly even estranged, and they're really not in a good position to inform us of the patient's preferences. And then the third sort of area for doubt is the assumption that the family member is committed to the patient's best interest. And it's not the worry that the family member wishes harm on the patient. The worry is that the family member is unable to separate their best interest from the patient's best interest. So they're responses in terms of decision making are really reflecting their own pain or distress or what will make them happiest rather than what's good for the patient. So all of these sort of devolve together to give us an increased obligation to evaluate the authenticity of their decisions. Okay, so it kind of lowers the threshold at which we start to have doubt about whether this family member really should have decisional authority, and in worst case scenario, possibly lead to the need to seek court intervention. So that's decision making. What about their involvement in the sort of day-to-day bedside care? Okay, so the first basis for why we ordinarily do that was that we can't provide effective care without attending to family needs. Okay? And this is where we need to step back and think a little bit about it and remember that, you know, our primary obligation, you know, as we all know, is to the patient. So when we're in these conflict situations, you know, that's the time to remind ourselves of sort of going back to basics. If we can't meet the needs of both, okay, our duty is to the patient. We must attend to that first, okay? And if we cannot meet the needs of the patient without, in some way, sort of putting a wedge a little bit between patient and family, then we have to do that. I mean, the moral analysis of that is pretty straightforward. Well, what about those sort of general duties? You know, as healthcare providers, it feels bad to be in these adversarial relationships with family members. That never feels good to us, okay? Well, on a strict analysis, our duty to help others, you know, the Good Samaritan duty to save the person who's drowning in Lake Erie, you know, is tied to the likelihood of success, okay? It would be great if we could always really be effective in providing support and help to families, but we sometimes cannot. They will not let us, or we don't have the skills. And if we are unable to, then we do not have the duty to. So, you know, that's kind of an escape clause that it's helpful to remind ourselves and the staff that you are only obligated to do that which you are able to do. Okay? Now that doesn't, you know, even the recognition that we are unable to do good for the family, it doesn't mean that we have no duties, okay? That we don't have a sort of ongoing duty to make sure that we're truly minimizing any harm that comes to them. Because remember, we've got the two arms here, doing good and avoiding harm. So it may not be that we can provide benefit, but we can at least pay attention to avoiding harm. Now that benefit burden analysis is pretty key to this, to the moral analysis of our duties to families and when we are obligated to take steps to put that wedge in place. And you'll see that I have a habit of annoyingly using the word precisely, okay? Because there's a tendency, because there's so much emotion in these situations, to really make some assumptions. And so we have to be careful here and do a really careful analysis of, you know, what exactly is the aspect of patient care or the patient need that's being impaired by the presence of this family, okay? It may be that it's harder for me as the doctor or the nurse or the social worker, but what exactly is it doing to the patient? Because the question isn't me, the question is the patient. So if I can meet the patient's needs, even though it's, you know, bothersome to me, then in fact the family's not interfering. So we want to ask that. We want to ask precisely how will it help the patient if we move that family member away or limit their decision making? What benefit will the patient derive from that? Okay? And really importantly, and this is the step I see we often sort of miss, what are the harms? Because if we intervene in family dynamics and we move families away, we have an obligation to say, what's the downside of that, basically? What's the harm of taking away that family member, changing their patterns, you know, keeping them out of the room, what have you? So here's the, you know, sort of nice sterile analysis that philosophers like to do, you know, as if the situation was ever this simple. So we start with asking, is the family interfering with care? And that means, again, how precisely is that interference happening? Or what decision is really contrary to the patient's best interest? Okay. If we can answer that question, we move to, have efforts to modify the family behavior really been maximized? And this actually, I didn't know how Kay was going to end her talk, but this is exactly her point, I think. You know, have we really tried family meetings? Have we brought in consultants? Have we listened to them? You know, have we tried a behavioral contract? Have we really done everything we can before taking that step of separating patient and family? Okay? Is there consensus among the team that, you know, about the harms and benefits, basically? Do we all agree about that? Because this is a big step. And how do we know we agree? Have we actually had a team conference? You know, is there consensus about that? Any disagreement? Have we tried the least intrusive approaches? Okay, this is the requirement for what we call proportionality. Okay, you know, if you slap me, I can slap you back, but I can't shoot you. You know, it has to be proportionate. So have we done the least intrusive things before we move to the big guns? Limit setting, regular meetings, negotiated agreements, that sort of thing. And then if we've done all those steps, I think we have the moral justification for that last step, which is to restrict visiting, to not allow them to make decisions, and worst case scenario, to take court action. So the summary of this is, under ordinary conditions, our obligations to patients include obligations to address family needs. That's a legitimate part of our moral duties. Independent from our obligation to the patient, we have general duties of beneficence to be helpful to family members. When there are characteristics or behaviors that threaten the patient well-being, the duties to the patient absolutely take precedence. Evaluating those duties requires pretty careful, pretty logical evaluation of the benefits and burdens. Our duties to the patient may, in fact, lead us to separating the family members from the patients, or at least trying to minimize their influence. Before we do that, though, we have to have that careful factual assessment and use the least intrusive means. And then, just because I can't take off my clinical hat entirely, words of caution, okay? I do worry a lot about the fact that we've swung too far with that pendulum, that we are so committed to, you know, the term I hear a lot is family-centered care, that that becomes family-directed care, and that is really defaulting our responsibility to the patient. We have to be careful, I think, that we assume behavior can never change. So we can never improve the situation. It's hopeless. Don't even try with that, you know, difficult mother. Or on the other hand, forgetting the fact that these are 20, 30, 50-year behavior patterns, and we're going to make a big difference in them. A tendency to let conflict and adversarial relations escalate before intervening. You know, ethicists often get called in on the 11th hour. You know, and it's understandable why that happens, but it's very difficult, as Kay showed us. If you let the situation get out of hand, it's pretty hard to change it then. And probably most common, just letting our feelings of frustration and irritation and personal affront and anger get in the way of that careful assessment.
I am a pediatric psychologist by training. I am not an expert on ethics. And my sense is when making ethical decisions, when considering parent-ectomy, the decisions are made usually on a case-by-case basis. What I'll be talking about here is a specific form of parent-ectomy that we perform on each and every kid and family that comes through the program that I'm involved with, which is the Pediatric Pain Rehabilitation Program at the Cleveland Clinic. So this is what I plan to go over in the next few minutes. I'll be telling you a little about the kids and families that we see and why we think parent-ectomy is appropriate, or our form of parent-ectomy is appropriate for each and every one of these families. I'll describe what it is that we actually do, so I'll be talking about what our parent-ectomy looks like, and then I'll go over, again, very briefly, some real-world outcome data that suggests to our team that we are making a difference and that the approach that we're using is an effective one. So the kids that we see are kids who have chronic pain conditions like complex regional pain, headache, fibromyalgia. They're kids whose pain has gotten in the way of their day-to-day functioning. So because of their pain, These kids are not able to go to school on a regular basis. They're not hanging out and doing things with their friends like their age peers. They're not able to stay involved in their sports or other activities. Now, this has been described by some as pain-associated disability syndrome. So this was defined in 1999 as a downward spiral of increasing pain-associated disability, which lasts for at least 3 months, for which symptom-focused strategies have not led to an acceptable resolution. So 2 things on that. I think this description or definition applies not just to the adolescent, him or herself, but to the family as well. And then just a point, the kids that we see are kids who have tried standard medical, physical, and psychological therapies, but have not responded satisfactorily. And it's for that reason these kids and their families are being referred to our program. Let me tell you a little about some of the common characteristics of these kids and families, and these are the reasons or factors that led us almost from the start to begin what we do. So for these kids and families, there is a strong belief that medications or surgical procedures are the only helpful strategies. These kids and families struggle to understand how psychosocial factors, stress, mood, emotions, can impact on their pain or how they function with pain. Now, point here, the kids that we see have very real pain. Their pain is not psychological or psychologically caused. However, psychological factors very much affect how these kids cope with and how they function with their pain. These kids and families struggle with accepting pain for what it is. They have trouble making a commitment to living despite pain, which is one of the things that we stress is going to be really important in terms of helping kids and their families move forward. Characteristic of our kids and families is this view that pain is synonymous with suffering. What we try to convey to our kids and families is that pain is pain, suffering is optional. It's a very hard sell at the beginning. Parents are often very fearful that by pushing the child, by making their child get out of bed, do things, go to school, be active, they will harm the child, and for that reason, they tend to pull back. They inadvertently encourage pain behaviors. So by that, I mean things like when a kid wakes up in the morning with a really bad headache, the parent allows the child to stay at home, not wanting the child to suffer more pain, feeling like, well, they're not going to be able to get much out of school if they have a headache anyway, so just stay home, which makes sense initially, but when it continues for a longer term, can create problems. These kids get additional sympathy, attention from their pain, which causes increased disability. It's not uncommon for us to find that not only is the child impacted by his or her pain, but parents and other family members are equally impacted. And when we find that, it just makes treatment and progress all that much harder. The approach that we take to pain and functional disability is a rehabilitation approach. So in comparison with a traditional pain management model, which is focused on helping either eliminate pain, make it go away, or reduce it significantly, we instead are focused on helping kids learn to function despite their pain. So in our eyes, an improvement in functioning is an improvement in their pain. And what we look at and what we consider in terms of good outcomes, especially at first, is whether the child is beginning to normalize his or her activity schedule. How are they coping? Is the coping better? How confident are they in managing their pain and being able to do the things not only that they need to do, but what they want to do? I'll describe the program. So our pain rehab program has 2 primary goals, and those are to help kids learn to handle or deal with their pain more effectively and more independently. Again, in terms of parent-ectomy, we see adolescents. The developmental task for adolescents is to become independent and autonomous. When a child is impacted by any chronic problem, pain or some other illness, that movement toward independence and autonomy is thwarted. And it's for that reason helping kids learn to help themselves, which is really the focus of our program, is particularly important. So we're focused not only on helping kids learn to manage their pain more independently, but also helping to normalize their activity, to get kids back to school, to get kids socializing and doing the things that their friends are doing. Care in our program is individualized but coordinated. What we do is we bring together an interdisciplinary model. So kids, while they're with us, are getting medical care. They're seeing psychology. They get a lot of rehabilitation therapies. So the way things are structured within the program, the schedule kids follow is very similar to that what you would have in school. So essentially, every hour on the hour, kids are involved in some kind of service or activity that is meant to address either the physical, psychological, or social parts of their pain and functional impairment. They're seen by physicians. They're followed by our nursing staff. They get individual psychological services. They meet in groups. Behavior plans are developed to help them function more independently. We provide a lot of physical therapy, occupational and pool therapy, so a minimum of 3 hours a day, again, designed to help kids get back on their feet and functioning independently. We also have a school program that attends to the academic needs that these kids present with. Many of the kids that we see are not attending school on a regular basis, or they're missing significant amounts of school. They are very far behind, and for that reason, while in the program, we're targeting that as well. So, in terms of the parent-ectomy, the way our program is structured is that most of the kids that we see are seen for 3 weeks. It will occasionally have kids for a little bit longer, but most of the kids are seen for 3 weeks. The first 2 weeks that kids are with us, they are admitted to our hospital as inpatients. During that first 2 weeks, kids are treated independent of or separately from their parents. So basically, we bring the kids in, we ask the parents to go home. And this was something, when we started this program 5 or 6 years ago, this was something that several of the subspecialists who were involved in starting the program were adamant about. They felt like the most important thing that we could do to help their patients get back on track was to get their parents out of their hair. Now, and to this day, we have people who refer to our program who insist, the reason they refer to Cleveland Clinic is because we do parent-ectomy. Now, there aren't many programs nationally who do this kind of work to begin with. Our program is unique in that we are the only program to routinely require an inpatient component to the program. And when people refer to us, they know that what we'll do is we're going to bring these kids in, we're going to ask their parents to leave. Now, as I go on, I'll talk about how, in my opinion, and in the services that we offer, you will see it's not just a matter of separating kids from parents. But I do think having the kids on the inpatient unit by themselves for a couple of weeks serves a number of important functions. One, it allows us to ensure that kids are in an environment where things are being done to help them learn to function again. So, one, we can attend to and essentially prescribe the amount of physical activity that these kids are getting. Most of these kids, in the weeks and months leading to their admission, are doing very little. They are spending the majority of their time at home, in their bedrooms, often laying in their beds, asleep. They come into our program from the get-go. They are moving. They are active. So, being inpatient, we can monitor and prescribe how much activity kids are involved in on a day-to-day basis. We can watch what they're eating. We can ensure that they are eating good meals on a regular basis. We can ensure that they are getting enough fluids over the course of the day. Many, if not all of the kids that we see have really bad sleep patterns by the time they get to us. Because of their pain, they have trouble falling asleep. They have trouble staying asleep. The majority of the kids' sleep schedules are characterized by going to bed at 1, 2, if not later in the morning, and then they sleep in through the morning, maybe even early afternoon. It isn't compatible with going to school and doing things that other adolescents do. So by having the kids inpatient, what we can accomplish is more control over their daily environment. Having them inpatient also allows us to expose them to our treatment philosophy, which is you can have a normal activity, you can have a normal life even though you have pain. You can have a good quality of life even though pain hasn't gone away altogether. The other huge thing about having the inpatient portion of the program is that it does allow us to interrupt that downward spiral. It allows us to break up whatever patterns or dances have evolved, often with good intention, but in a maladaptive way. So I think what it does is it allows us to separate kids and parents and break up these patterns. It gives kids and parents a chance to just be away from each other. It's respite. But not only that, and the respite is important because for these kids and families, again, by the time they get to us, the average chronicity of pain in the kids that we see, again, remember that we're seeing adolescents, but the average chronicity of pain is about 2.5 years. So even though chronologically these are young people, they've been at their problems for a long time. And like I said earlier, they've seen multiple providers, they've tried all kinds of treatments. When they get to us, two things. Not only do the kids' lives revolve around their pain and problems with function, but the lives of their parents, their lives of their families revolve around this as well. They're burned out, they're feeling really helpless. So the inpatient, in many ways, because we do a lot of work to help the kids get better, and as you'll see, to help the parents get better, it allows for a reset, a normalization, which then when we bring the kids and parents together, I think allows for the moving forward that these kids and families have not been able to do at home on their own. Now, after the first couple of weeks, then we transition kids into a day hospital program. Now, the content of the day hospital program, what these kids are doing during the time that they're with us, 8 to 4, 8 to 5, it's very similar to what they've done in the first couple of weeks. What's different, though, is at the end of the day, they go home with their parents. Now, for some kids, the kids who are local, regional, that may mean they actually go home. A big portion of who we see comes from out of state. So it typically means they go back to the Ronald McDonald House, maybe they're in a hotel with their families. It's not really home, but it's much closer. And the idea behind the day hospital week is this is our attempt to facilitate transition into something that will look more like what it's going to be like when kids actually do return home while they're still under our care. And that week of transition allows us to see what are the real problems that these kids and families are going to face on discharge and try to address and support them while they're still seeing us on a daily basis. If you look at our setup, in many ways, the conditions for improvement during the first 2 weeks for the kids, they're almost ideal. And it's what we see. The challenges come when we move to the day hospital program. And that's why we have the program set up like we do, so we can better understand what happens in the real world and support these families when they make that transition. So we're seeing these kids individually and doing what we do. Doesn't mean that we're not doing anything with the parents. So over the course of the admission, we are working with parents both individually and in groups, separate from their kids, on helping them better understand both the physical and psychological parts of their kids' pain and how we treat it. We're teaching them how to manage the pain behaviors that have become problematic. We're also working with them on how to anticipate the problems they may encounter when they go home and developing strategies to prevent the recurrence of functional disability upon discharge. As well, and this is especially as we get into the latter part of the second week of the program and clearly through the third week of the program, as kids are doing PT, OT, when they're in the pool, we begin to have parents join them in those sessions so that parents can see what their kids really are capable of doing, so that the parents can observe and learn from our staff and how we interact and how we encourage kids to push ahead even when it's hard. As we move later into the second week, as we move into the third week, we're also beginning to involve parents more in the psychological services that we offer in the family therapy sessions. The other thing we do with parents while their kids are being treated is we spend time trying to understand where they are, not just psychologically, but also physically. What we find is, I had alluded to this before, not only has the pain impaired the adolescents, who are the focus, or the primary focus of our treatment, the pain has also impaired these parents. So we find that aside from taking their kids to the doctor, spending hours on end trying to figure out what to do to help their kids, these parents are very inactive. They themselves are doing very little. They're not eating right. They're not sleeping good. A lot of these parents are up very late at night on the internet trying to find the cure, trying to find the cause, trying to find the cure. They're not sleeping good. By the time they get to us, sometimes the parents look as bad as the kids. When it's necessary, and we've done this on a number of occasions, we have a parent come in whose chronic pain problems may be very similar to, if not worse, than their kids. We've referred them to the adult pain rehab program. At times we've had to refer to psychiatry when we feel that the amount of depression, the anxiety, the sense of helplessness is truly getting in the way of good caregiving. Now, one of the neurologists that we work with is always on me. He argues that we should have each and every parent that we bring in seen by psychiatry. They should all be seen. They should all be treated. And I keep telling him that we can't just do that. We can't just say, you have to go to psychiatry as part of this program. But I think what he's picking up on, and appropriately, is how much the pain their kids are struggling with has impacted on these parents emotionally and functionally. So when it does feel to our team like that kind of referral is appropriate, we will find a way to make that recommendation. And usually the sell is that in order to be the best caregiver you can be to your kid, we think it would be useful if you saw someone from psychiatry. And while parents themselves don't want to, our parents don't want to look at their own issues or concerns, when we frame it in terms of how in the end it will benefit their kids, they're more open to this referral. So does it work? We collect a bunch of data, including lots of more standardized, psychometrically good questionnaires, checklists, and measures. We get objective physical data that show how kids are progressing physically. What I'll focus on here are just some very basic, but I think really important real-world data. So on this slide, I just talk about how the results I'll present are based on 177 kids that we saw, average age of 15, seen in the program. Complex regional pain was the most common diagnosis, followed in turn by headache, abdominal pain, and then fibromyalgia. As I said earlier, these kids have had pain for more than 2 years. So on this slide, across the top are the various real-world outcome measures that I'll speak to, the number of school days that kids are missing in a week, the number of work days that parents are missing as a result of their kids' pain, number of never good at this, the number of hospital days that kids are experiencing because of their pain, and then pain ratings. And then on the left-hand side, top to bottom, are the data collection points. So looking at where kids fell at admission, and then where they were 2 years after they left the program, and then 3 years. And as you can see in each column, so as an example for school days missed, when kids came into the program, they were missing about 3.5 days. They were missing the majority of the school week. And then you look 2 years, 3 years out, they're missing almost no school. Similarly, parents were missing a good chunk of time from work because of their kids' problems. At 3-year follow-up, that has gone down to 0 days. You see the reduction in hospital days. And then pain ratings show a clinically significant, statistically significant decrease. But I'll point out that these kids are still reporting pain 3 years later. But look at the difference in terms of the functioning. So to me, is parent-ectomy responsible for these outcomes? I don't know that we can say that with certainty. We throw a lot at these kids and families. But I can tell you that clinically, lots of parents talk about how invaluable that 2-week period of inpatient care when we had their kids separated out from parents was in terms of the improvement that kids made while they were with us. So finally, we were asked to attend to a few questions as part of our presentation. And so now I'll just touch briefly on this, and I'm sure when we do discussion, we'll be talking about this as well. The first question had to do with how important is it to manage the patient-caregiver relationship when we feel that the caregiver problems are beginning to interfere with what's going on? And my answer to that question is attention to that relationship is huge. It's critical. We view pain and functional disability from a biopsychosocial perspective, which means that to understand and effectively treat pain and functional disability, one needs to attend not just to the physical, but to the psychological and social factors that are making the problems worse. And to me, critical among these are the relationship between the adolescent and the parent. And for that reason, I think attention to that is critical. What about ensuring that if caregivers are having problems, that they get the care needed? Again, we feel it's important. I outlined how we will make referrals as appropriate. If we feel that it falls within the scope of what we're doing, we'll make attempts to address these problems. But more often than not, when we feel like the depression or anxiety or hopelessness is really that bad that this individual can no longer provide for the child, then we make the appropriate referrals to ensure the support and resources are there. The final question had to do, when in the process do you begin to attend to the relationship? When in the process do you begin to attend to these problems? And in my opinion, as a clinician, the earlier you get to these, the better in terms of, again, my focus is on the kids. But ultimately, what we've come to realize, and our sense is this is embodied within our program, that if you're going to be effective with the kids, you have to work with the parents. And that separation initially may be a part of it, but in the end, there has to be a plan for the reunification and a planning for future after they're no longer with us here in Cleveland. So.
Average 15-year-old, 16-year-old, 17-year-old who's able to understand the ramifications or in their own state valve? Are they trapped?
No, they're not trapped.
We have been doing this program for about 5 or 6 years now, and on average we see between 100 and 110 patients a year. In that time, there have only been a handful of kids and families that have opted out. So it's interesting. I was toying with the title of elective parent-ectomy. But as I thought about it, it really is an elective because some of these kids and probably more of these parents don't really like some of what we do. But they know that it's a part of what we do. I think more often than not, when just thinking through the kids who have elected or the families that have elected out, it's more because the kids or families didn't feel like they were like the other patients and families in the program, or it was what we were asking more of the child was far too much, or they didn't believe or accept that this truly was the approach. Now, at the beginning, the majority of the referrals that we got for this program were from subspecialists at the clinic who knew what we did and had a good feel for which kids were going to do better. As our program grew, we started to get referrals from a broader range of places. And then I think there was more struggling with the program philosophy, the structure, the required separation. Over the past year, what we have required is that we see each and every kid and family before we bring them into the program. which accomplishes two things. One, we can determine which kids and families truly are appropriate for what we do. There has to be an acceptance of what we do. But it also allows the patients and their families to lay their eyes on us, see who we are, see what the facility looks like, talk with other kids and families. So they are entering into it with much more information going in. And I think for that reason, we haven't had as much of a problem with people wanting to leave earlier. They're making the decision to enter into this. They may not agree with all of it, but they know going in what they're going to get, and for that reason, they're hanging in there with us.
With minimal amount of encouragement or influence, or I don't want to say coercion because that's already within the program?
Yes.
Question over here, and then.
All right. So I really like that this model of parent-ectomy is actually a different way of thinking of family-centered care, but I think it represents that. But I'm wondering if you have any data with regards to the adolescents that have gone through this program and how they do transition into the adult setting. So then do they continue to experience success in the adult setting, or do they then have a similar program in the adult rehabilitation setting?
The challenge we're finding in terms of doing any kind of follow-up data collection is that we're seeing these kids at 15, 16 years of age. We've been able to get good data, actually. The amount of response to 3- and 4-year data collections has really surprised us. The hard part is these kids get older, they're going off to college, they're moving on their own, and we haven't been able to really follow them for much longer than that. I like our data. I like the data that we've gotten to this point, or the 3- and 4-year data. And to me, it suggests that kids after leaving our program are on the right trajectory and moving toward and maintaining the improvement in functioning that they make while they're with us.
Was there anybody on the treatment team that was from an African-American background or who had any better success at speaking to the mother or to the daughter who might be from a visible minority or another cultural background to try to address that, or getting cultural consultation or culture broker?
Well, I think our team is, I'm the only social worker that works with the team, but there are nurse practitioners, and certainly the nurses that deliver care on the nursing floor is a very diverse group. And there's diversity within our team. It's a good question, and I think part of, as I was listening today and kind of rethinking some of this, there were just such barriers to try to, I don't think any of us, and there were probably 20 different, from members of our team to regular care providers on the nursing floor. There just didn't seem to be success that anyone had with trying to break through these concrete barriers, with what information was given, with how we could try to intervene in some way. So I think your point's a very valid one, and something that I think certainly try to pay attention to. I just felt there were such roadblocks. So I don't think it was a case that there were not people that were working with them that they that may have shared similar racial and ethical, or racial and other cultural similarities.
There was a question here, and then I'm going to ask a question, and then we'll take some more from the audience.
For all three panelists, I've done a lot of work internationally and even nationally with different cultural groups. And the concept of autonomy that we typically use is very westernized. And from a community perspective, where community is viewed as an autonomous whole, as opposed to the individual, how might you tackle some of the issues arising, not specifically your cases, but issues arising where you have community and
You know, if I can make a comment, you know, I think in a good example, and I've been working the last couple of weeks with a young man, also just about the last 10 days, just a newly diagnosed 22-year-old who is from an Amish community about 2 hours from Cleveland. And we've probably in our years in transplanting almost 1,600 people having heart transplants, have maybe only transplanted 6 to 8 Amish individuals. So certainly when I go in that room, there are multiple family members. So I think that's a very good example, and really try to be extremely mindful of the differences between Amish communities and how consistently some of them adhere to their Amish lifestyle and protocol. In the 3 or 4 that we've transplanted recently, you know, we had one who they so strictly adhered to their Amish lifestyle, and the family working with now probably a little bit on the other end of the continuum. So take that into account. At the same time, though, there are times, you know, I did my assessment with him by himself, which was interesting and very helpful because he had described to us some very minimal alcohol use. And he was always asked these questions by the doctor and other team members coming in when his parents were present. It then was revealed to me when I spoke with him by himself that he had daily alcohol use, but on the weekends he would consume anywhere from 2 to 3 cases of beer. And he had a DUI. He was the only one in his family who had a driver's license. So how much of that would have been revealed? His parents certainly knew some of it, but I think there were some components of his alcohol history. His sister had had a transplant at our program 8 years ago. She was older, and he revealed that she's been drinking and smoking after transplant, and that the father has almost been condoning of this behavior. So I took all of, you know, recognizing who they all are, and they're all a part of his life very much, and it's so important I be aware of that culture. At the same time, I had to view him as he was also my client, in that I needed to really get a thorough assessment, and I was going to probably do that best with, you know, by himself.
I just want to make just a very short comment that, you know, cultural issues, of course, I think we try to be sensitive in terms of adjusting our care plan and what have you to recognize it. But I think in our situations here that we're talking about, the time that it is really important is in that benefit burden analysis, because I think, you know, inevitably we evaluate patient outcomes in terms of our definition of what's good, without really thinking hard about, you know, in that particular culture or religion or society or family, what's the good to them? Because that should really be our touchstone. You know, it may not be a good we can serve, and we may end up saying, I can't serve that purpose, but I think we have to be really careful when we do the benefit burden analysis.
Just related to that, for me, the key or an essential first step is really in those initial meetings with kids and families is identifying what it is that they really want to get from the services that we offer. And I can say that for our population, what we consistently hear back is parents want their kids to have their lives back. And so I think our success comes from educating and helping parents, kids and parents, to understand how each of the components of our program will help toward achievement of that goals. And it's clearly within our program when kids and parents understand that and accept and begin to embrace what we're doing, that we can be successful. When the kids and parents don't accept that, when they struggle with what we're trying to do, for whatever differences there are, they don't do as well in the program.
I had a question about the second case that you presented, Kay. It seemed that there were several facets and several points in time where the patient's care was actually being interfered with by the relationship with the mother. And so this may be unfair, but I'm going to first ask Barb if you had a gut feeling while hearing about that case, what you might have recommended. And I'm also curious to know what the Ethics Committee did. You told us what the Ombudsman recommended, but I was curious about what the Ethics Committee recommended in that case.
Well, I think, I'm not sure the best way to think about this is the mother's behavior interfering with the care as much as, the duo, the dyad, had some behavioral patterns that were dysfunctional in terms of her biologic outcomes. So I think what we probably would have recommended, or as a first step, were the things that I think Kay identified as coming too late. This seems like the perfect case for a contract with the things that are tolerable and the things that are not tolerable. With both of them, I think trying to separate those two, it sounds to me, would have been impossible at the outset. So I would probably suggest a contract with both of them to start with. And attention to seeing if there was anybody who could have some trust with this family. I mean, clearly they had none. So maybe focusing on, giving them that control. Who do you want to be your key person?
That's a good point. So I guess in answering your question, first of all, this did not go before our hospital ethics committee. So our ethicist I would say his greatest involvement was talking with our team, and when we collaborated in our multidisciplinary team meetings, again, giving some opinions about ways of approaching. He had a brief meeting with the patient. She was by herself at the time, and she again was very resistive in speaking to him. He attempted to speak with the mother, and again, she spoke with him very, very briefly. So his interactions with the family were quite limited. They were more directed at us. The comments about, the suggestions about having a contract, and it didn't typically happen, but this was such a splintering of our team, because I think, again, we just did not have, I think it showed to me how really limited at times, even though we're in the healthcare profession, the understanding of boundaries, of crossing over boundaries at times when we work with families, and how really at times people aren't savvy to that and the implications. So the contract really never developed. That was discussed, and there was typically always some reason we never quite got to that.